we'd like you to also look up, and because that addresses your studio audience. So look up at the cameras occasionally and the audience, both. And with that, I just need to know when my technical guy is ready. We have Skype calls, we have phone number calls, we have emails coming in. So it's going to be a very interactive adventure, shall I say. 1 minute.
1 minute.
1 minute to go. It's not America's Got Talent or anything.
Yeah, that's for sure.
You don't have to break out in song and dance. It's not a debate. You don't have to remember 3 whole things at the same time. And I hear my technical director is ready. So with that note, I'm going to hand it over to your master of ceremonies, Dr. Jury.
Good afternoon, and welcome to Finding Hope, Prevention, Early Detection, and Treatment of Pancreatic Cancer, a continuing medical education series to benefit patients affected by pancreatic cancer or the diseases leading up to pancreatic cancer. I'm Robert Jury. I'm the moderator of the program today, a pancreatic surgeon and a system leader of the Digestive Health Center of Excellence for the Beaumont Health System. Today's program is sponsored by the Beaumont Digestive Health Center of Excellence and Oakland University William Beaumont School of Medicine. This important educational initiative is supported by the Shirley and Coleman Mopper Pancreas Cancer Fund and the Beaumont Foundation. During the past week, our team of experts from Beaumont who make up today's panel have provided a series of lectures and learning modules that are available on the internet at meded.beaumont.com. meded.beaumont.edu. And let's take a moment to introduce each. Get started. I want to invite our internet viewers to join in on the roundtable discussion. We'll start with some questions that were sent in to us during the week and some submitted by our faculty members. We encourage you to participate and by contacting us by telephone, Skype, or through the internet at digestivehealth@beaumont.edu. Even if you're watching a recorded version of this program, you can still send your questions by email and we'll have our experts respond to you. So finally, at the end of this program, we'll provide some information about gaining continuing medical education program for those physicians who are participating. So with that, let's first get started with our first question.
And we originally thought of BRCA1 and 2 as specific for breast and ovarian cancer. In the last couple years, there's been a recognition that those 2 gene mutations, when present in an individual, increase that individual's risk of pancreas cancer. As a matter of fact, that risk now has been translated to about a 7% or up to 7% lifetime risk of pancreas cancer in a person who carries a mutation in the BRCA2 gene. And likewise in the BRCA1 gene, there's also a slightly lower but still a heightened risk. There's also another syndrome called Lynch syndrome, which is particularly thought of as a colon cancer hereditary risk syndrome. But it is well known that pancreas cancer is part of that syndrome as well. So for that, you look for colon cancer, uterine cancer, perhaps pancreas cancer within a family, but as well as other cancers that we will talk about probably later on in this conversation. So there are red flags, but I think the one that I really want to highlight is the breast ovarian, particularly in an individual of Ashkenazi Jewish ancestry, where the chance of finding a mutation, if that person has pancreas cancer in the BRCA1 and 2 genes, is quite significant. So I think that those are the things we try to teach our residents and clinicians to recognize.
Okay, so with that, I'd like to turn the question to Dr. Cannon. So if we have a patient who has a family member that was affected by pancreatic cancer and tests positive for the BRCA gene, how would we screen that patient? At what point do we start to screen, and what screening techniques might we consider?
That particular patient would be a good candidate for screening. You mentioned one first-degree relative with pancreatic cancer and they're BRCA2 positive. So that actually would meet some of the criteria, although one has to remember that the criteria for screening and surveillance is really, we're learning as we go, so to speak. There's not any real set criteria in terms of screening and surveillance yet. But in this particular instance that you mentioned, this would be a good candidate. And There's several different modalities out there that have been looked at over the last, really just the last decade, and probably the best would be that of endoscopic ultrasound. There's been several studies out in the last decade that have looked comparing endoscopic ultrasound with MRI, with CT scan, combinations of both, going on to ERCP. There is no set standard of care of which particular imaging modality to do, but a lot of the studies have found that most of the neoplasms that have been picked up when we're screening were on the very first study, not so much on the surveillance follow-ups, but on the very first study. So we probably want to pick a really good one first. And we'd probably go with something like endoscopic ultrasound or MRI or both of them together.
Thanks. All right, I have a question now for the entire panel. So current evidence on screening is clearly still incomplete. So apart from patients that have solid masses or cysts in the pancreas that have suspicious features, are any of us prepared to recommend to a patient that they have a preventative or prophylactic pancreatectomy on the basis of screening? Julie, have you ever done a preventative pancreatectomy?
No.
Mike, would you be ready to recommend to call us up and say that you've got somebody that needs their pancreas out because their risk is so high?
Well, you know, everything's individualized. That's something you have to talk with the patient, and obviously there has been some studies where they have found some irregularities. The typical findings noted on endoscopic ultrasound in particular are that of a chronic pancreatitis look. And this is, we're speaking in patients who do not have chronic pancreatitis, yet you look at them and they have these findings. You put a needle in there and you perhaps, you know, it's very difficult to detect, but you could biopsy or put a needle in there. You might get lucky and find these intraepithelial neoplastic lesions. And in a patient like that with a strong family history, yes, I would refer them to an experienced pancreatic surgeon to have that discussion.
Okay, with that, I want to turn our discussion to a question that came in for Dr. Wilson. Dr. Wilson gave a talk this week on the use of biomarkers in our effort to detect pancreatic cancer at an earlier stage. And in his talk, Dr. Wilson described some of the research that's going on through the biobank at Beaumont Hospital in terms of searching for those biomarkers. And in that, we saw the use of laser capture microdissection for isolating cells. And George, a question came in. Can you describe a little bit more, tell us a little bit more about how laser capture microdissection is done?
Yes, well, I brought a movie along, so hopefully we can show that.
Can we show the movie?
And I can talk over the movie whilst it's running. So what we want to do with laser capture microdissection is to isolate individual cells or individual groups of cells so that we can study them in more detail rather than looking at the tumor as a whole. And so in this study, we were looking at IPMN, intraductal papillary mucinous neoplasm, which is a premalignant condition. And some of these are very low grade, some are very high grade. We wanted to separate out the different types of grade. So laser capture microdissection allows us to do that. So with this, it's a microscope slide. We drop a cap down onto the slide, which has a thermoplastic coating, and then we fire an infrared laser through that. So what you're seeing us here is firing the laser through at areas that we've identified with a pathologist, which are representing these different grades of tumor. The infrared laser basically will meld the tissue onto the plastic cover. And then with a UV laser, we come in a bit later on in the sequence, and we then cut around these areas. And then what we can actually simply do is take the cap away. The cells that we've lasered will be attached to the cap. We can take those out. We can extract the RNA, the DNA, or the protein from those cells, and then subject them to the analysis that we want to do. In this case, it was looking at their global gene expression. So what we're able to do with this technique then is to look at different grades of tumor and then compare the gene expression very specifically within those to try and discover biomarkers for the future, which may help us to define tumors as low grade, not needing as severe surgery, or much more likely to be malignant. So laser capture is a very specialized technique that we use to enable that specific capture of cells.
Okay, thank you, George. Okay. I have a question for Dr. Stein, and I know that Dr. Stein has a video that perhaps we can get ready. So, Julie, for patients, particularly those with neuroendocrine tumors, we use liver-directed therapy and treat tumors in the liver rather aggressively with a variety of combinations of surgery and other ways of dealing with the liver. And in your talk, you described ablation of liver tumors. Can you describe briefly how that's done, or how do we get rid of tumors in the liver other than through cutting them out surgically?
Well, first of all, I'm glad that you brought up the question in that way, because I do want to point out that liver-directed therapy at this point in time is most useful for us for pancreatic neuroendocrine cancers as opposed to pancreatic adenocarcinoma. Ablation is a general term to essentially mean kill the tumor cells that are present within the liver. Thermal ablation or heat ablation is the most common of those types. That can be microwave, that can be radiofrequency ablation. The example that I brought today is a video that shows a radiofrequency ablation needle entering the area of tumor, which would be localized by ultrasound or CT, and then that needle opens up with several tines that have radiofrequency waves that heat up the tissue. Meanwhile, we're watching a generator that tells us the temperature that is achieved, and we know when the cells are no longer going to be alive. The next picture after the video, I also had a picture of what we see on a patient scan after an ablation. And essentially we see a large cavity that is filled with fluid as the tumor cells, the dead tumor cells, get reabsorbed, and then that cavity over time gradually will shrink down on the subsequent films, and you can see that there.
As part of that, we go to great lengths to try and achieve negative or clear surgical margins. And so that means to remove the tumor entirely, checking those margins to ensure that we've done everything within our capability of getting it out completely. You can see that there is a point where the pancreas is divided on the image, and that would be what we would call the pancreatic resection margin to remove a tumor like the one shown here. During surgery, we give tissue to the pathologist. The pathologist look at that tissue, and if that margin is negative, we can save the remaining part of the pancreas, particularly with the hope of avoiding insulin-dependent diabetes if that part of the pancreas isn't affected by cancer and still functions. In certain instances, that margin may have cancer cells or the suspicion of cancer cells, in which case we would take out the entire pancreas. So the short answer to the question is we make every effort that we can within reason to remove the tumor completely, and sometimes that requires removal of the entire pancreas. But for those patients that have had partial pancreatectomies or Whipple procedures, that taking more of it out doesn't really improve the long-term survival. Another question from the audience.
Well, I'm a 9.5 year survivor, and I have
Let's hold on for the microphone, because I know this is an important question.
I'm Beulah.
And Beulah, hold it close to your mouth.
Is this close enough?
Close enough.
Okay, I'm a 9.5 year survivor, and I had the Whipple. But I was questioning this because my two sisters and my mother had died with pancreatic cancer. And I wanted to know, should my kids be checked out for pancreatic cancer?
Yeah, that's a very, very important question. And I think that there's a couple things I think that are important in your question. Number one is that this is a perfect example of the frustration that we all find in treating pancreatic cancer. 85% of patients are not candidates for potentially curative treatment at the time of discovery. You were fortunate that we did find your tumor at a stage in which giving you that chance for cure was possible, and there's nothing that makes us happier than to be able to see you here and to know that. At the same time, your other family members didn't have that chance, which speaks to the importance of being able to identify these biomarkers, the blood tests that Dr. Wilson is working so hard in the lab to help us identify, and the screening that Dr. Cannon and others are helping us to do. So the question I wanted to turn to Dr. Zakalik and Dr. Cannon again, because this really is a key issue that keeps coming up. In order to do better, we've got to find it earlier. What should we tell Beulah's several children? I have a question for Dr. Zacco in that same line. Pete, in your talks this week, you talked about multiple endocrine neoplasia syndromes, MEN1, MEN2, that are really important inherited syndromes that have to do with the endocrine tumors of the pancreas. So is there genetic testing available for those patients?
Yeah, absolutely. To something that Julie mentioned earlier, Dr. Stein mentioned about the difference between neuroendocrine tumors of the pancreas and what we call garden variety or adenocarcinoma. They're different, and the advantage we have in neuroendocrine tumors is sometimes they are functional, and several of them are related genetically with multiple tumors throughout the parathyroids, a lot of what I deal with thyroid cancer, as well as the pancreas. There are genetic tests that are available for these conditions called MEN1 or MEN2, multiple endocrine neoplasia syndromes 1 and 2. The extension of this discussion, the advantage that we have in those syndromes is that if you are genetically tested and you have a gene that's positive, not only can you start to do some of the screening that Dr. Cannon talked about with adenocarcinoma, but we are at the point right now, for example, with MEN2, that if you are a family that has and has carried that gene and you carry it down to the next generation, if you have a gene-positive child, for example, with MEN2A, that child is pretty much guaranteed 100% that they will develop one aspect of the multiple endocrine syndrome. In this case, it would be thyroid cancer, a particular type, called medullary. And so we would advocate, based purely on genetic testing, that that child have their thyroid removed prophylactically. The question would then be, are we getting to the point with pancreas cancer, can we find a gene that would allow us to predict with that much certainty that you would have pancreatic cancer, and then go into the question earlier, should we just take the pancreas out? I don't think we're there quite yet with the pancreas, but for some of the organs we are when they're involved with these multiple endocrine tumors.
Thanks. Okay, we have a call that just came in. Bella from Bloomfield Hills is a survivor of pancreatic cancer, and her daughter wants to know how to go about having genetic testing done. So Dana or Carrie, wanted to tell us what the patient's supposed to do?
In terms of genetic testing, how to go about, well, if somebody is concerned that they may have a genetic syndrome, at our institution we have a comprehensive genetic counseling program where someone can call up and be seen by both a genetic counselor as well as a physician, where we will take a very careful family history and determine if there is indeed reason to proceed with genetic testing for specific genes. There are a variety of different genes, so one has to be really careful to take a thorough family history to hone in on the correct gene, because these genetic tests are, at this point, rather expensive, so we want to make sure that we are efficient at honing in on the correct gene. And then when we get the result, we meet with patients and go through what we call post-test counseling, where we discuss the various interventions, their benefits versus limitations, and then steer the person to the right next specialist to do the surveillance or preventative surgery. So that process is rather efficient in our institution, and we are very happy to see any patients who have any questions regarding family history and genetic testing.
This is almost as frequently altered in cancer as P53, which most people know. But KRAS is one of the key genes in transmitting signals from the outside the cell to inside the cell, signals controlling its growth, its differentiation, its survival. And in a normal cell, this is under very tight control. KRAS gets switched on. It transmits the signal from growth factors through to DNA, and then it's switched off, and that's the end of it. In cancers, a single point mutation in the KRAS gene can cause it to be turned on all the time. So it's like an on-off switch. Now it's on all the time, which means that that cell no longer is responding to inhibitory growth signals from the outside. So this is the first real step in the development of a cancer.
We have a question from the audience.
I have it's really two-part question from a layperson. Number one is when we hear about pancreatic cancer, it's always diagnosed, too late, fourth stage, it seems. And I'm wondering why that is, why we don't have, the kind of testing that can detect it, like with mammograms and pap smears and PSAs. And then the second part is, so why did Steve Jobs live for so long, and his cancer didn't seem to be as terminal so quickly?
Okay, who wants to take that question? Well, I'll start. I think the first part of the question is, why can't we diagnose it at an earlier stage? And I think the problem is that in the earliest stages, the symptoms that someone might experience are very nonspecific. And I think each of our survivors who's here in the audience today will tell you that there probably was a time where they had some discomfort or they had some weight loss or other things. And so the symptoms that might occur early are very, very nonspecific. And so often people will get put through workups to look for more simple and common things. And so the real cause may be initially overlooked. I think in the cases where we have the best chance are the patients who develop jaundice by blockage of the bile duct, which occurs at an earlier stage in the disease. And even a small tumor located at the bottom of the bile duct or at the opening of the bile duct can lead to jaundice and lead to its discovery. We just don't have that screening tool yet that can be applied on a widespread basis and be cost effective and be safe. And I think we also have to remember that when we screen populations for diseases and we find things, that finding has to be specific, because that can also lead to other tests. It can lead to operations, and each of those things not only has a cost to it, but has a risk. Okay, with regard, George?
Yeah, I was just going to say that, we talked earlier about RAS being one of the first changes which lead to pancreas cancer, but that change could happen 15, 20 years before you actually are able to detect the tumor. But in that time, the tumor has been developing. It doesn't look very different to normal pancreas for a long time, and more mutations occur. And by the time we can detect the tumor, which may be a millimeter or a few millimeters in size, it's already accumulated a large number of genetic changes which are driving a very rapid phase of growth. So often in the clinic, when we see a tumor and detect it, we're in a phase where it's exploding in terms of growth rate. And so we have a very small window to be able to treat those tumors. So the earlier we can detect them, then the more chance we have.
So did Steve Jobs outwit nature or outsmart nature? Why did Steve Jobs live for so long?
Okay, Dr. Zacco.
I'll try to answer that one. The thing about Steve Jobs, remember, and I mentioned it earlier, is that we talk a lot about pancreatic cancer, but I don't want everyone to think that that's just a term for all the cancers that we deal with. There are the pancreatic cancers that are the garden variety tumors that we talk about that still to this date have a more dismal prognosis. The neuroendocrine type of pancreatic cancer, because of its indolent biologic behavior, we have sometimes a little bit of a better chance in achieving survival, and the survival statistics are better. What he had was a tumor that was successfully operated on years ago, and then as Dr. Stein mentioned, there was this window, what we call a disease-free survival, before it came back into the liver. And because it was the only area, it is very reasonable after a number of years, if the disease doesn't go to other parts of the body and metastasize, to go ahead and do a definitive organ transplantation and remove that liver and give a new liver. And in many cases, that'll work very successfully. Obviously, the downside is that that transplanted organ, in order to continue to survive, you have to take immunosuppressant drugs, and your immune system is brought down a little bit, and so there is a recurrence risk. I think my colleagues would agree that if you had adenocarcinoma or pancreatic cancer that we talk about in the more normal term that presented in the liver, medically we would never provide a liver transplant for an individual with that because we know that there is really, unfortunately, no hope. But for a neuroendocrine tumor, it's very reasonable, and it's done in many transplant centers across the country.
Okay, we have just a few minutes left, but there's one important question I want to get out to Carrie. Other than the opportunity to work with this wonderful panel of experts, what has been, or what would you describe as your greatest reward as a nurse navigator helping patients with pancreas cancer?
I think to truly be there for them. Sometimes they call and they just want someone to talk to, or just have reassurance that there is hope, that there's people that care about them, that we're aggressive, that they have a window of opportunity to jump on, that there's a team of dedicated professionals that are interested, that have a compassion, that have passion for the disease, that they're not just out there by themselves, and that they don't have to believe all the internet statistics that are out there, that they have people that they can go to. And it's truly a benefit for the caretakers, that they have people that they can call if they need advice, and being able to take care of that population is truly rewarding.
Anybody like to add to that? Okay, our final question, and I think we have a graphic that we can put up, and the final question is, does anybody survive pancreatic cancer? I think we have a few people in the audience here that can attest to that. And if we have the photo. Well, the answer to that question is not nearly as many people as we would like to survive pancreatic cancer do. And yet, I think that you can all see from the committed team that we have here today that we are continuing that fight. And this photo comes from Purple Stride 2011. It's a Pancreas Cancer Action Network's walk at the Detroit Zoo. And these are a group of survivors who were out there on the stage to prove that the answer to that question is yes. So, in closing, I would just like to thank everybody for their participation. I want to thank all of my colleagues who worked so hard to develop their lectures. I would like to encourage everyone who hasn't yet watched the lectures to go to meded.beaumont.edu. The lectures are available on YouTube and also on iTunes University through Oakland University, William Beaumont School of Medicine. And once again, I'd like to thank everybody. You done? Good job. Thanks. Thank you very much, Dr.